Well, good evening. It's so great to have you join us again on Facebook Live on behalf of the ARIS Foundation. As you know, it's a nonprofit foundation that uniquely is positioned to help women with breast cancer, both educate them and help them support them directly to get breast reconstruction. Very, very pleased and honored to have with us an incredible professor from Sloan Kettering, Dr. Melissa Pilewskie, who's an associate attending in the Department of Surgery at Memorial Sloan Kettering in New York. And we're going to talk a little bit about risks associated with breast cancer. And there's so many things that people have asked us about and also want to know. So, Melissa, welcome.
Thank you. Thank you, really. It's a pleasure. Events like this are so nice to be part of, and I'm happy to share and answer these questions, but I appreciate the invitation.
So it's our pleasure and honor to have you. So give us an overview of the current breast statistics as they are today.
Yeah, so what we know, unfortunately, breast cancer remains the leading diagnosis of cancer, non-skin cancer among American women, and is still the second leading cause of cancer death in this country. And so it's something that affects a large number of women here. The numbers currently are about 268,000 cases of invasive cancer diagnosed annually, and about 63,000 cases of non-invasive, or what we call DCIS, stage 0 breast cancer. So in total, over 300,000 cases diagnosed annually. And what that means for each woman, the numbers that we think about are that 1 in 8 women in the United States will have a breast cancer diagnosis in their lifetime. And that equates to about a 12% lifetime risk.
Yeah, man, that's high. So, what factors can influence that risk for a woman for developing breast cancer, Melissa?
Yeah, I think that this is important to think about. So when we say 12%, that obviously isn't the same number for everybody. There are some women who fall above, both above and below that number. And the risk factors that really impact that number, I group into 2 categories: things we have control over and things that we don't, or modifiable versus non-modifiable factors. The modifiable things that we can control, tend to be more modest risk factors, things like obesity, not exercising, drinking too much alcohol, avoiding combination hormone replacement therapy. That's an important one that has changed over the years. And also something that not a lot of women think about, but having a history of chest wall radiation, treatment for lymphoma at a young age. But the more common risk factors, the things that we really counsel women on, are those things that we don't have any control over. The most common being female and increasing age, but really having a really strong family history of breast cancer, having a genetic mutation, an abnormal gene that you're born with that predisposes you to this disease. Dense breast tissue is something that millions of women experience. They get their mammogram letter and it says, talk to your doctor about your dense tissue and what you should do about this. And then there's another group of these breast lesions, what we call high-risk breast lesions, which are things that you would get. You have your mammogram, there's some calcifications, you have a biopsy, and the good news is there's no cancer, but it shows some abnormal cells, some atypical cells, or something called lobular carcinoma in situ, which are not cancers, but things that once those have developed can increase your likelihood of later on getting a cancer.
Okay. So, these high-risk women that you're talking about, what should they do different in their screening recommendations today?
Yeah, that's really the first thing that we often talk to these women about. We have a high-risk program, and when we're counseling people, we're assessing their risk based on all these different factors and then deciding what's the right imaging to make sure that we're doing our best to not miss something. We know that mammogram remains gold standard for everybody. So that is part of all women's screening recommendations. And then the question becomes, who should have more than that? So for the highest risk groups, women with a known gene mutation, the most common are these BRCA1 and 2 mutations. Women with very strong family histories, or those who've had chest wall radiation, we add an MRI each year in addition to their mammogram. For the kind of the middle group, these moderate risk populations, oftentimes we'll add an ultrasound for additional screening. But it's actually a pretty hot topic in the research world right now, looking at newer techniques, things like contrast enhanced mammogram or short sequence MRI, to try and identify what's the sweet spot, what's the best imaging for moderate risk women.
So, Melissa, what about ultrasound. Shouldn't most women get ultrasound with their mammogram? I know it's obviously recommended for patients with high density breast, but what's the downside of that? Because it's a very minimal, non-invasive procedure that has no radiation.
Non-invasive, it is frequently added. The most common reason that we add an ultrasound is for women who have dense breast tissue, and that's actually very common. So a
Right.
lot of women will have a supplemental ultrasound in addition to their mammogram because of density itself, which is probably the number one indication for it. The downside is that it's really user dependent and it's not very sensitive. So it actually doesn't find that many extra cancers.
So what do you recommend for those patients with dense breasts? I mean,
Yeah,
obviously,
so that is our standard, and it also depends on if they have dense breast tissue plus other risk factors. We do a lot of additional ultrasound for density, and we also at our center will do a lot of those intermediate imaging that I was talking about. Contrast enhanced mammogram
right.
is frequently used here. A lot of women are getting tomosynthesis or 3D mammograms as part of their imaging for that
Well,
reason.
will any of those supplant mammography? Because as you know, a lot of women do not like
Yeah,
mammography.
unfortunately, we get asked this all the time,
I know you do. That's why
and it's
I need to hear it from you.
right. So it doesn't take the place of having a mammogram. These are in addition to having a mammogram. And there are certain things that we only see on mammogram. Frequently, calcifications, which is often the first sign of an early cancer, are only detected on mammogram. And it's really the only imaging strategy that has been proven to improve survival. And so it really remains the gold standard.
Gold standard. I know. So what are the options for reducing your risk, the medical options? I mean, I know you mentioned some of them. Obviously, obesity is one, and
Right. Yeah. And I mean, those things are important. The lifestyle factors have been a really hot topic in the news. We see it in, covers of magazines. They're important to know because we can control them and they
right.
have a lot of other health benefits. So we know that obesity increases risk of postmenopausal breast cancer and that women who exercise routinely have been shown to have a slight reduction. Alcohol consumption has consistently been shown that women who drink more than one drink per day on average have a slight increased risk. These are small risk factors. So they're important, but they're not going to change our risk the way that other medical modifications can. And so for the women who are really at increased risk because of the things we've talked about, family history and these atypical breast lesions and such, the most common method for risk reduction is chemoprevention, which is taking a pill, a medication that either blocks or reduces estrogen to prevent a breast cancer from ever forming. And these are pills that are used to treat breast cancer all the time, but they're also well studied for prevention. When it's used for this purpose, it's a daily medication that women take usually for about 5 years.
So what type of patient would do that? Would you recommend consider doing that as a risk in the high risk group or?
Yeah, yeah. So, when you'll hear me use moderate versus high risk a lot, and it really depends on the numbers associated with risk. But women that we've been talking about here we consider high risk to be greater than 20% lifetime risk of developing breast cancer compared to that 12% kind of general risk that I mentioned. So
Right.
women with a strong family history or these atypical breast biopsies are really kind of the right population to consider taking these medications. What we know is that if you take this, it reduces your risk by greater than 50%. So it's really effective. It's been studied in thousands of women. And we also know, and we've studied this, that few women who are eligible for these medications actually choose to take them. And so in our center, about a quarter of women who, we have this conversation and we discuss it actually choose to start the medication.
And why is that? Tell us about
Well,
that.
what we have found is that one of the main reasons is fear of side effects.
Right.
Healthy women aren't often inclined to start taking a medication that could have side effects that impacts their quality of life. Rare, but some serious side effects as well with these medications. So, that's where we're really balancing risk and benefit and why it's not the right option for all women, across the board who are average risk.
Yeah, and I hear that all the time too from my patients is that, it's kind of risk benefit ratio. So what else can they do if you say, listen, you're in a high risk group, you're not ready for any, prophylactic, What else can they do?
Yeah, well, medically, these pills are our option right now. Surgically, the other thing we talk about with really the highest risk women is considering doing bilateral mastectomies or
Right.
removing the tissue that's at risk. And that, because obviously that has much greater risk associated with it and changes with our body, we reserve for the highest risk populations, really those women with gene mutations and really strong family histories or people who've had chest wall radiation.
Right. So that kind of segues into the different types of breast cancer. Can you kind of give us an idea of the different types so that, when people are, obviously faced with this diagnosis, there are many different variations.
Right. When I hear this question, the first thing I think about it from a type of breast cancer is the cell of origin. Where is it developing from? So, on a report, we will frequently see that something's a ductal versus a lobular cancer. So, most breast cancers start from the cells that line the milk duct. And the second most common starts in the lobule where milk is produced. So, they're really starting within the glands of the breast tissue. The other term that we think about a lot is just the stage of a cancer, and that helps us think about the type and strategies for treatment. But a stage is defined by the size of a tumor in the breast, as well as the involvement of lymph nodes underneath the arm or in the surrounding area, and then whether or not cancer has spread anyplace else in the body.
So
The
what do you think about, so when these patients present to you, well, obviously they're treated in obviously, at Sloan Kettering and places like that. They're obviously, it's comprehensive care. But what do you tell a patient that's really looking for that type? If they're not at Sloan Kettering, they're not in New York, they're not in Houston. How do they get
so
that care?
Yeah, I think that, you can get good cancer care in lots of places. There are excellent cancer centers all across the country. And I think it's worth asking the surgeon or physician that you're seeing if this is their area of expertise, if this is all that they do, making sure that this is something that they're comfortable with. They're getting a second opinion if they're uncertain about the recommendations that they're getting.
Yeah.
I grew up in the Midwest and am from Ohio, and I'm referring my family members and friends all the time to places that are local where they get excellent care.
Right. And I think it's, a true breast care center. They're accredited all around the country. And, and obviously they're not, obviously as big as some of the other centers that I just mentioned, but they do provide great care.
Yeah,
And
I
it's
think it's
personalized care.
important to see that there's a dedicated team, that you get a
Right.
surgeon, an oncologist, a radiologist, and they only do breast cancer,
Right.
and that they all work together in a multidisciplinary fashion. And I think those are important things to pay attention to.
Right. Breast cancer is a team sport
Right,
for us in medicine, very much so. And so what about other things like, when you hear about receptors for breast
right.
cancer, what does
So
that
that's
mean? What do people need to know about that?
the receptors are really the other piece of information that defines the type of a cancer that something is. So, when we say breast cancer, that's really a big umbrella generic term. And then there are these subtypes within that. And they're defined by these three receptors, the hormones, estrogen and progesterone, and this protein called HER2. And the purpose of checking these is to ask what is feeding the cancer cell. Most breast cancers, about 80%, are fed by hormones in our body. About 20% are fed by this HER2 protein, and then there's a cohort that are negative for all three, what we term triple negative. And these results of the receptors become really important when we're thinking about the medical treatment. There are
And
medications that
why
block
is that
these
important?
receptors.
Tell us
And
tell
so
us why that's important.
the treatments that we have, a lot of the targeted medicines specifically block these receptors. So those would only work if they're positive. Using a medication that blocks a receptor that is not important to this cancer cell would not be an effective treatment.
Right. So if you have triple negative, that's a challenge.
It's a challenge right now because we don't have a specific target for that the way we do for the other types, but we have, it's why kind of standard systemic chemotherapy remains part of the treatment for triple negative cancers, because we don't have another target. Lots of
Tell us
research in
about.
this area, really exciting area. It's a big area of interest for immunotherapy and other targets, trying to find something that we can target on those cells.
Right. So, what are some general strategies for treating invasive breast cancer when you talk to
Yeah, in
patients about?
general, we really split treatment into two categories: the local treatment, meaning how do we treat the breast and the lymph nodes, and then the systemic or the full body treatment. Our goal in treating a breast cancer is obviously to remove the tumor and prevent that from growing, but importantly, preventing these cells from spreading any place. And so treatment always encompasses both of those areas. And so the options for local treatment are surgery and radiation. And so surgery is, obviously where we come into play, but there we're thinking about doing a lumpectomy or removing just the area of the tumor versus a mastectomy, which is removing the entire breast, and frequently also checking the lymph nodes or removing lymph nodes underneath the arm. And then the addition of radiation is another layer of protection to that local tissue. The systemic treatment is the medical treatment here. And so this would include things like chemotherapy, these targeted agents. There are very effective drugs now that target the HER2 protein, and these oral pills that block the hormones.
Good. So, where does breast reconstruction fit in this paradigm?
Breast reconstruction is such an important part of all of this conversation. So obviously, anytime we're talking about doing a mastectomy for someone, either because they need to based on their tumor size or the growth pattern, or because that's their choice, at the end of the day, part of this conversation is always the breast surgeon removing the tissue and the plastic surgeon doing the reconstruction. And it's important that women know that this is an option and it's available to everyone. And it's kind of part of our normal conversation. But I know at a lot of places that's not always the case.
That is very true, and that's why, of course, as a plastic surgeon, that certainly rings true to me every day, and I think it's so important because it is an essential part of the team approach to breast cancer. So what are the new things on the horizon in surgical trials and that really are probably going to hopefully really have a positive impact?
Yeah, I mean, there's a couple things. This is one of the most common questions that we get asked in any of these arenas. One thing that I'm really passionate about that I do a lot of research on is looking for alternative options for risk reduction. So when we talked about chemo prevention, I mentioned that less than a quarter of women who are eligible for these drugs actually choose to take them because of the potential side effects. And so we are working with a number of other hospitals across the country right now to study the concept of topical chemo prevention, meaning can we use the same drugs that we know work and apply them just to the breast, put them in a lotion or a cream that get applied to the organ of interest, you put it right on the skin over the breast. And if this works, and the preliminary studies actually look really promising from this, but if we get
Really?
good distribution throughout the breast tissue and see equal efficacy, you can get the benefit in the breast tissue without the side effects because you really get minimal uptake throughout the rest of the body by not
Which
taking this
which
orally.
drugs have they done it with topically? Which of these
We
drugs?
have a current trial that's open that's using comparing oral tamoxifen versus the topical form, which is 4-hydroxytamoxifen. So
Really?
yeah, well-studied agents. Yeah.
No,
And,
no, I know. Of course they are, and of course tamoxifen is great, but it has a lot of side effects. So,
right. And
so
so,
topically, is that significant reduction, or is this early data? Because that's very intriguing.
yeah, it is very intriguing. So there are a couple of small pre-surgical window trials where women before their surgery were randomized either to take this orally or apply it on the breast. And they saw nearly equivalent reduction in proliferation of tumors in the breast. And so now the studies we have are the kind of next step of larger series. So we're enrolling 100 women in the current trial that we have. And from a prevention standpoint, if we see promising data here, this would really change the landscape for millions of women who
Oh,
I think would be very open to daily taking a shower and applying a cream to their breast and getting potentially excellent benefit here with risk reduction, and I think really minimal side effects that we're going to see from this. Studies
well,
are ongoing, so we need time to do all of this, but
right. No, that's very intriguing. But I mean, of course, that's early data. When would that be? Something that would be obviously
well,
clinically.
for the current open trial, so there's been kind of 3 studies in this series. The first was to see when we apply the gel to the breast, does it distribute throughout all the breast tissue? We want to make sure that it's not all ending up in the tissue right underneath the skin. And so that study is closed. The second study is really showing, is it as good as oral tamoxifen at potentially treating or reducing proliferation of lesions in the breast? And we only need 20 more patients in this study. So it's
Really?
almost completed accrual. And the third study is really looking at toxicity to the skin application, which is a standard when we're studying any kind
Right.
of drug application to make sure that it's tolerable.
That that may be a game changer
Right. Yeah, I think it's really exciting. So
because
there's a
that's the
lot of
biggest problem with tamoxifen is that patients just, I mean, it's a challenge because
the
of the side
challenge,
effects.
and the challenges I think are real and perceived. There's actually studies showing that a lot of women attribute the side effects of chemotherapy to chemoprevention. There's a lot of miseducation and misunderstanding
True.
about some of the
But
potential side effects of these drugs. But, while some women take this and tolerate it very well, it definitely really impedes quality of life for some patients who are on that medication.
okay. Here, I have a
Um,
question. Go
yeah.
ahead. I have a question for you. It says, I've had a prophylactic double mastectomy due to uh, PTEN and implants placed. Now I have a free flap, a DIP flap reconstruction. Now she has to have that. Is my cancer risk the same as if I used implants, if I had a flap versus implants?
Yeah, so that's a good question. So the type of reconstruction that a woman has doesn't have any impact on future cancer development. So both are
100%.
really just as safe as the other. And also important to know that having reconstruction, regardless of which type, doesn't impact your surgeon's or your oncologist's ability to do your follow-up and to do your exam and to
Right.
check for any cancer development.
And that's very well studied in multiple great institutional studies. The other thing is, and it's great, is that she says, I'm 22 years old and looking at birth control options. Is birth control still an option for me, increasing my risk, and should I avoid it?
So, that becomes a really individual question that I think, each person should really discuss with their doctor. But in general, my thought on this is that after you've had prophylactic mastectomies, your risk is really substantially reduced. I
Right.
mean, 90 to 95%. And so, if there are strong reasons to use other medications such as birth control, that, honestly, the data shows that maybe it's a small associated risk, but long term is not a great risk factor. And if that's the right choice for you, then after having prophylactic mastectomy, I would be comfortable with that.
Yeah. No, I totally agree with you. I mean, it's very high, and I think, but these are great questions. So I'm very intrigued by topical tamoxifen. Is that only been done at Sloan Kettering, or is that a
No, so
multi-institutional study?
it's a multi-institutional NCI funded series of trials. The lead on these studies is Seema Khan out of Northwestern in Chicago, but there are a
Wonderful.
number of centers that are involved in these. Yeah.
That's awesome. So if everything goes well, was that within a year potentially that could be
I think that
potentially
would be
or
wishful
longer?
thinking.
Longer?
I think with all of these,
I mean, I'm not gonna hold you to it,
yeah,
but
the nice thing
that's
with these
probably the most
studies.
that's gonna be probably the most common, I mean, the most sought after question after this
Right.
Facebook Live.
The nice thing about these studies is that we get the results pretty quickly because we get the answers at the time of surgery. We don't have to wait 5 years for these initial
Right,
trials. The next series would be that next step comparing it for prevention, which would take a long time, to get the final results.
right.
But once these studies accrue, we actually get the results fairly quickly.
Yeah, that's true.
But it to me, doing these projects probably 2 years is a little bit more of a realistic
I know,
timeline.
I know that, but that's exciting. It's very, very, smart.
Yeah. From a
It's
research
long.
standpoint, the other, just to switch gears for a second, the other kind of big area from a breast surgery research standpoint is looking at ways to minimize the surgery that we do on the lymph nodes. So,
Right,
removing lymph nodes underneath the arm for women with breast cancer has been a standard part of the operation for years since we've been doing the surgery. And it's very effective. It checks the lymph nodes, it treats any cancer that's there. But the biggest feared side effect of that is lymphedema, which is getting swelling in the arm, and that can be a real lifelong nuisance for women who develop that. And so there's a huge drive to study different ways that we can make sure we treat cancer effectively, but minimize how many lymph nodes we have to remove. And so we've found that we can safely do small surgery, something called a sentinel node biopsy, where we're just sampling a couple of lymph nodes. when the cancer has not gone to the lymph nodes. But now there are studies showing that there are populations, even when cancer is in the lymph nodes, that we can do smaller procedures, either smaller surgery or adding radiation instead of surgery. And from a plastic surgery standpoint, there's interest in looking at different ways to reconstruct the lymphatics and to see if that would aid in decreasing some of these side effects. So I think that that's another kind of big area that we're going to be hearing about in the next couple of years.
Yeah, absolutely. Because it certainly, when you take lymph nodes, I mean, as we know, the chances for lymphedema increase over time, and then with radiation, it's even more so. And
Right.
those can be very debilitating to patients.
Yeah, it's a challenge, and it can really be lifelong. It is not something that we have an easy fix for right now, unfortunately.
Right. No, I think that's very, very important. So what other new things are on the horizon that you've been doing or thinking about that I think, obviously there's a lot of great new things and positive stuff that you've talked about.
Yeah, so I mean, these are two areas that I'm really involved in. The other, I would say, kind of big global area of hot research that a lot of people are asking about and hearing about is the role of immunotherapy, or studies that are going on looking for targets for triple negative cancer, like we discussed,
Right.
identifying these more aggressive breast cancers that right now we don't have the same effective targets or medications for. And so a lot of medical oncology research in that arena.
Yeah.
And every year, every meeting I go to, there's another study looking at different medications and which would be the best next option.
Yeah. I mean, and certainly that's actually all for most of cancer therapy. It's immunotherapy, and that's more directed therapy that has a lot more less morbidity for our patients. So no, I think that's great.
Yeah,
So
and I think the challenge now is just finding the right population, because we know for breast cancer that it hasn't worked across the board for all tumor types. And so it's studying which cohort or which subtype would really be best suited for these trials.
okay. One other question that I just thought of was, why don't you tell uh, patients when should they get their first mammogram? I know that it's in some
Very
parts of the world
controversial.
it's controversial. I'm just because I get this from my patients all the time. They say, "Well, my OB-GYN said I didn't need it." I'm going, "Really?" So what is
Yeah.
the gold standard, and what should we tell our patients today? The
So
basic
there remains variation in different societies' recommendations.
society.
Yeah, so they range anywhere from 40 to 50. They range whether it should be every year or every other year. And those are really based on statistics and the likelihood of finding a cancer in a different age group. At nearly all cancer centers, the recommendation remains to do annual screening starting at the age of 40. And, unfortunately, we see cancers in young women, and they tend to be more aggressive cancers. And so,
I
not
know.
an age group that we really want to be eliminating screening or doing it less frequently in. And so, that's the standard for average risk women. For women with other risk factors, then we have to modify that based on why they're at increased risk. So, people with family history, we look at the age of the family members, and we want to start screening younger than that. There's actually a very long guidelines for different genetic mutations at which age to start screening based on the risk associated with each gene. So for people with risk factors, that number changes.
Right. But I'm really glad you said that 40 and above, you have to do it annually. I get that pushback
Yeah,
because you're right. Certain societies say, well, you should do it every other year. You should start at age 50. But I really think it's important to do that. And then if there's any dense breasts, you should do an ultrasound. I actually get ultrasound on most of my patients because, as you said, dense breasts is very, very common.
right.
And
I mean,
so,
density is tricky for two reasons. One is that it can make the mammogram harder to read. It literally can hide little things, but it also is an independent risk factor in and of itself.
right.
And so for both of those reasons, having some additional screening is helpful.
Yeah. No, that's great. Well, great. I had to I had to get that plug in because so many times people say, "Well, that's not what my doctor told me." So, in closing, any other comments that you want to mention? You've been phenomenal. I really, it's been very
Well, thank you. I appreciate the
informational.
time. I hope that this is helpful information. We covered kind of a very broad spectrum of information, but I honestly, I hope to just put in a plug for the work that we're doing. as you said, I think it's really exciting. If we can come up with some non-toxic options for women, I think that we will really change the opportunities for prevention here.
Absolutely. And then the compliance. I mean, that's amazing for
Right.
patients to do that. So
yeah, we know that about a third of our patients who start chemo prevention will stop because of the side effects.
That's amazing. Well, thanks so much. So, and just again, on behalf of heirs, we provide, support in reconstructive surgery for women that cannot afford it after having a mastectomy. And so if you want to, and we've actually helped more women than we've had before this last year during the pandemic. So please, if you want to help women in need, any amount is appreciated. And you can go onto our heirs website and make a donation. And we really, and obviously it'll help us contribute to having the support for women that want to have reconstructive surgery and to do Facebook Lives with amazing experts like you, Melissa. And I cannot thank you enough for all of your time, and especially in the evening. And good luck to you, and stay safe in New York.
Thank you. I appreciate it. Stay well to everybody here too.
All right. Take care. Thank you so much. Yeah, bye.
Bye.
So